The diuretics or the renal system and renal physiology is all about maintaining osmotic balance. Now, renal physiology basically is reduced to something very simple, which is what goes in must come out. Throughout the nephron and along the proximal convoluted tubule down the thin descending loop, the loop of Henle, and in the distal convoluted tubule, we have a number of antiporters and a number of co-transporters and sodium-specific co-transporters. Basically, they are responsible for maintaining a volume load and for maintaining electrolyte reabsorption. Before we look at the diuretics, it is essential for us to understand as to the basic anatomy of the nephron and what really happens throughout the tubule. Now, we always assume a normal glomerular filtration rate of 120 mL per minute, and what is filtered is usually anything that is not protein bound or is in the free form. While the non-ionized form of any drug may also be filtered, it will eventually become reabsorbed if it remains lipid soluble or non-ionized. In the proximal convoluted tubule, as you move down the proximal convoluted tubule and at the junction of the cortex and medulla, there is significant reabsorption of water and bicarbonate. Most of the bicarb actually gets absorbed here. As we progress down the thin descending limb of the loop of Henle, more water is reabsorbed, and then up through the thick ascending limb of loop of Henle. This is where the sodium-potassium chloride co-transporters exist, and at this stage we have significant reabsorption of potassium, calcium, sodium, magnesium, and chloride. As we progress to the distal convoluted tubule, this is where you have the sodium chloride co-transporter that predominantly causes reabsorption of sodium and chloride. Further down in the collecting duct, this is where you have the reabsorption of water and urea, and a small degree of exchange of potassium and hydrogen. Now, as far as where the individual diuretics act, the first one is the carbonic anhydrase inhibitors that basically inhibit the carbonic anhydrase enzyme. The osmotic diuretics basically act at the junction of the cortex and medulla and are the only set of diuretics that will prevent the reabsorption of water and not move sodium. The loop diuretics are considered to be the most potent of all the diuretics and act in the thick ascending limb of the loop of Henle and inhibit the sodium-potassium chloride co-transporter. Then the thiazide diuretics inhibit the sodium chloride co-transporter in the distal convoluted tubule, and your potassium-sparing agents and your aldosterone antagonists basically act in the collecting duct. Let's look at the diuretics in general. The whole idea of the diuretics is to eliminate and excrete excess fluid along with electrolytes. The thiazides will excrete only sodium and chloride and retain calcium, whereas the loop diuretics such as furosemide is the most potent of all and will basically cause an excretion of all electrolytes and a significant amount of water. They subsequently reduce sodium and water reabsorption. They will maintain osmotic balance, and most of the time the way the diuretics are acting is that they are modulating the sodium co-transporters and the antiporters. Ultimately, they will increase the rate of urine formation. As a result, you have an increase in urine flow. You have a change in electrolyte reabsorption or secretion, ultimately causing diuresis and increased sodium excretion, and it is the loss of water that ultimately causes a reduction in extracellular volume, and a reduction in edema, and also a reduction in blood pressure. The first ones are the osmotic diuretics. Now, the osmotic diuretics that constitute mannitol and urea are usually very freely filtered at the glomerulus and will undergo minimal reabsorption by the renal tubules. They primarily and are about the only ones that will inhibit the reabsorption of water in the proximal convoluted tubule and basically increase the excretion of water relative to sodium. They are also able to inhibit water reabsorption also in the thin descending limb of the loop of Henle and the collecting duct. So as a result, they will excrete water relative to sodium. The osmotic diuretics also have the ability to basically remove water from intracellular compartments and therefore will increase the extracellular fluid volume. As a result, you have an increased urine flow with very small or no loss of sodium, and as a result your urine osmolarity will actually go down. They will increase water excretion in preference to sodium and are used in situations of preventing anuria that may happen in situations of hemolysis or rhabdomyolysis, where you have a very high risk of renal dysfunction or shutdown. They are used to reduce intracranial pressure and short-term reduction of intraocular pressure in situations of glaucoma, but they're not considered first line for the treatment of glaucoma, and also to increase the excretion of nephrotoxic substances and also to increase the excretion of certain anti-cancer drugs such as cisplatin. The typical adverse effects that you're likely to see with mannitol and urea is dehydration, which is dose dependent, nausea and vomiting, hypernatremia and chills. The next, as we move down the proximal convoluted tubule at the junction of the cortex and medulla, are the carbonic anhydrase inhibitors, namely acetazolamide and dorzolamide. They will block the carbonic anhydrase both on the luminal membrane and inside the proximal tubule cells. As soon as you inhibit the carbonic anhydrase, it will reduce the secretion of hydrogen through the sodium-hydrogen antiporter. Subsequently, the driving force or the electrogenic gradient for the reabsorption of sodium is dissipated, and this will basically reduce the reabsorption of sodium. At the same time, because it is inhibiting the carbonic anhydrase enzyme, it will significantly reduce the reabsorption or the reduction of reabsorption of bicarbonate, and as a result you have up to 80% reduction in the reabsorption of bicarb. This causes a significant increase in bicarb excretion and will also cause potassium secretion into the tubular lumen. The carbonic anhydrase inhibitors are usually the most potent in being able to reduce the reabsorption of bicarbonate significantly. Subsequently, one of the first line is they're indicated to treat chronic metabolic acidosis. They are used to eliminate weak acids in the treatment of acute mountain sickness because they will reduce pulmonary and cerebral edema. And also carbonic anhydrase inhibitors are excellent in the treatment of glaucoma, particularly in the treatment of closed angle glaucoma, because they will significantly reduce the amount of bicarbonate that it will be increasing the aqueous humor production, and subsequently will also increase the intraocular. One of the typical side effects associated with carbonic anhydrase inhibitors is due to the fact that it significantly increases bicarbonate excretion by 80%. The patient runs a very high risk of metabolic acidosis. The other side effects are urticaria, pruritus, Stevens-Johnson syndrome, photosensitivity, hypokalemia, which is dose dependent, and renal calculi, because calcium basically precipitates in an alkaline environment. The next ones are the thiazide diuretics. The thiazide diuretics constitute the hydrochlorothiazide, chlorthalidone, metolazone, and indapamide. The thiazide diuretics all act basically in the distal convoluted tubule and inhibit the sodium chloride cotransporter, and therefore will significantly inhibit sodium and water reabsorption. Thiazides also have the ability to mobilize sodium from arteriolar walls and therefore reduce the encroachment on the lumen of the blood vessels by sodium. They also increase the excretion of potassium. They will increase the reabsorption of calcium. They retain calcium. And one other mechanism of action of the thiazides is they actually induce prostaglandin formation, particularly PGE2, that improves renal perfusion. Thiazides are first-line therapy for the treatment of hypertension, particularly hydrochlorothiazide. And a low dose is quite effective in controlling blood pressure, preventing myocardial infarctions, strokes, and congestive heart failure. Always remember that thiazides are usually ineffective in renal dysfunction, particularly if glomerular filtration rate falls below 8 mL per minute. The thiazides and their adverse effects are typically hypokalemia, hyponatremia, hypomagnesemia, hypercalcemia, hyperuricemia, hyperlipidemia, and lithium toxicity. Both the loop diuretics and the thiazide diuretics have the ability to precipitate hyperuricemia and hyperlipidemia. This is because of the osmotic changes they induce. They may also cause gastrointestinal disturbances. The loop diuretics are the most potent of all the diuretics because they inhibit the sodium-potassium chloride cotransporter in the thick ascending limb of the loop of Henle, and furosemide is the prototype. As a result, they will significantly increase sodium and water reabsorption and will increase the excretion of potassium, sodium, water, magnesium, calcium, and chloride. They are extremely rapid acting and are also indicated in patients who have renal compromise because they will significantly increase urinary output. They are used for treating edema, refractory edema, particularly congestive heart failure, pulmonary edema, acute renal failure to increase urinary outflow, hypercalcemia, hyperkalemia, and also oliguria and anuria. Because they're extremely potent in excreting all the salts and water, they may cause volume depletion, metabolic alkalosis, hypermagnesemia, hypocalcemia, also hyperuricemia, hyperlipidemia, and ototoxicity. The potassium-sparing diuretics, often referred to as the aldosterone antagonists, are spironolactone and eplerenone. They are potassium-sparing and are used as an adjunct, particularly with potassium-wasting diuretics. They will antagonize the effects of aldosterone. They will slow sodium conductance. They will inhibit the expression of sodium channels, and they will slow down the action of the sodium-potassium ATPase pump, which is the driving force behind potassium secretion. They are, as I said, used as an adjunct with other diuretics to prevent hypokalemia, and they will also inhibit sodium reabsorption. They are indicated in heart failure because they will directly reduce cardiofibrosis and also for the reduction of asides associated with hepatic cirrhosis or nephrotic syndrome. With the potassium-sparing diuretics, you run a risk of metabolic acidosis and azotemia. Always remember that spironolactone has significant anti-androgen effects and will cause a loss of libido, and in your male patient will induce gynecomastia. Therefore, it is safer to use eplerenone in your male patients rather than spironolactone. And this is just a recap of the side effects of your classes of diuretics. One correction could you please make: in the thiazides, the major side effects would be hypercalcemia, not hypocalcemia.